Feeding and Eating Disorders. Deborah K. Katzman, Mark L. Norris. 9 Eating disorders, EDS, are mental disorders characterized by disturbances in body image, weight control, and/or dietary patterns. In the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, an updated and expanded section summarizes feeding and EDS that include 1. Anorexia nervosa, and 2. Bulimia nervosa, BN, 3. Binge eating disorder, BED, 4. Avoidant/restrictive food intake disorder, ARFID, 5. Pica, 6. Rumination disorder, 7. Other specified feeding or eating disorder, OSFD, and 8. Unspecified feeding or eating disorder, USFD. The focus of this chapter is on EDS seen in adults, AN, BN, and BED. Other feeding and EDS, including pica, rumination disorder, and ARFID, are discussed only briefly. Although feeding and EDS are classified as mental disorders, their associated behaviors commonly result in and present with medical sequelae, many of which are GI. Because associated chronic undernutrition, overweight, and/or purging behaviors often result in medical complications that can be serious, chronic, and life-threatening, individuals with feeding and EDS benefit from the ongoing care of a multidisciplinary treatment team. Indeed, AN and BN are among the mental disorders with the highest mortality. 2 Reviews suggest that GI complications are among the most prevalent experienced by patients with EDS. Epidemiology. EDS have been described across diverse global settings, although epidemiologic data are best established for populations in North America and Europe. Most of the published epidemiologic data for feeding and EDS predate the revised diagnostic criteria published in the DSM-5. As expected, given the changes in DSM-5 that aim to diminish the proportions of patients in residual categories, early studies suggest that the prevalence and incidence of AN, BN, and BED are higher, while proportional representation in the residual categories, previously ED not otherwise specified NOS and now OSFD and USFD, have decreased. 3 Of note, few studies to date have investigated incidence and prevalence rates of ARFID, pica, or rumination using the DSM-5. A recent systematic review drawing upon DSM-5 feeding and ED populations suggests that the prevalence rate for AN ranges from 1.7% to 3.6%, with a point prevalence of 0.67% to 1.2%. 4 Although BN has traditionally been more common than AN, the paucity of studies drawing upon DSM-5 populations has yet to establish this conclusively. BN has most commonly been assessed using point prevalence. 2 separate studies reported near identical point prevalence rates for BN of 0.6% in girls and women. 4 A recent interview-based study revealed higher lifetime prevalence rates for BN compared with AN, 2.6% versus 0.8%, respectively. 0.5 point prevalence rates for BED have ranged from 0.62% to 3.6%, female subjects only and males and female subjects combined, respectively. 0.4, 6, 7 lifetime prevalence rates for OSFD are reported to be 0.3% in male subjects and 0.6% in female subjects. 4, 8 with a point prevalence rate of 0% in male subjects and 2.4% in a sample of male and female subjects. 4, 8 lifetime prevalence rates for USFD range from 0.2% to 0.9% among male and female subjects. 8, 9 relatively high prevalence rates are also reported for specific symptoms associated with disordered eating. In 2017, 6% of school-going female adolescents in the U.S. reported vomiting or laxative use. 5.9% reported taking diet pills, powders, or liquids without a doctor's advice to lose weight or to prevent weight gain, and 17.4% reported fasting within the previous month to lose weight. 10 EDS occur across ethnically and socio-economically diverse populations, but each of the EDS is more common in women than in men. Historically, boys and men have accounted for less than 10% of individuals with AN, 10% of those with BN, and 40% of those with BED. 11, 12 studies have identified that approximately 14% 13, 14 of children and adolescents admitted to adolescent inpatient ED programs, and as many as 22.5% of individuals in a pediatric ED day treatment program met the DSM-5 diagnosis for ARFID. Patients were younger, had longer duration of illness, were more likely to be male compared with those who had an or BN, and were commonly diagnosed with comorbid psychiatric and/or medical symptoms. 13. Prevalence data on pica in the general population are unavailable and may vary widely in certain demographic strata. A recent systematic review of prevalence rates of DSM-5 feeding and EDS failed to identify any study that included pica or ARFID. 4 Whereas pica appears to be uncommon in healthy children in the U.S., pica eating has been reported to be relatively more prevalent among U.S. children treated for sickle cell disease, adults with iron deficiency, institutionalized individuals, some school-age populations in Africa, and in some populations of pregnant women, e.g., in Africa. 15 The prevalence of rumination disorder is unknown, but it can occur in both children and adults. 15 Causative factors. Although incompletely understood, the cause of EDS is almost certainly multifactorial, with psychodevelopmental 16, socio-cultural 17 and genetic 18 contributions to risk. Exposure to risk factors for dieting appears to elevate risk for an NBN 18-19, just as childhood exposure to negative comments about weight and shape elevate risk for BED. 20 Body dissatisfaction in a social context in which thinness 21-22 self-efficacy and control are valued may be an important means whereby dieting is initiated and disordered eating attitudes and behaviors ensue. Dietary restraint may precipitate a cycle of hunger, binge eating, and purging. 23 Among numerous risk correlates, childhood GI complaints have been found associated with earlier age of onset and greater severity of BN in a retrospective study. 24 And picky eating and digestive problems were found prospectively associated with an in adolescence. 16 It has been suggested that physiologic vulnerabilities may increase risk for an ED. Neurobiological targets have been identified as possibly playing a role in the pathogenesis of an BN and BED. For decades, researchers have studied the psychobiology of EDS and the neurophysiologic correlates and determinants of energy intake, hunger, and satiety. Findings highlight the multifactorial and phenotypically diverse nature of eating behavior. For example, energy intake is influenced by complex interactions among signaling molecules from peripheral systems, e.g., GI peptides, vagal stimulation, and CNS neuropeptides and neuroamines. As is true of the search for obesity treatments, it is unlikely that single mechanisms will become the basis of therapeutic interventions for EDS. However, the greater our understanding of the physiology of ingestive behavior, the more likely we are to establish integrated therapy models in the future. There is a vast amount of literature on this topic, and what follows is simply a brief overview of the more commonly investigated mechanisms. Satiety. Serotonin has long been a focus of attention for its possible role in disrupted satiety. There is substantial evidence that altered 5-hydroxytryptamine, 5-HT, serotonin, functioning contributes to dysregulated appetite, mood, and impulse control in EDS, and that such alteration persists after recovery from an NBN, possibly reflecting premorbid vulnerability. 25-26 There also is evidence that CCK levels are altered in ED populations. Findings for an are inconsistent. Although there is some evidence that young women with an have high levels of pre- and postprandial CCK that may impede treatment progress by contributing to postprandial nausea and vomiting. 27-28 Other reports have shown decreased CCK compared with controls. 29 In patients with BN, there is consistent evidence for an impaired satiety response, characterized by a blunted postprandial CCK response as well as delayed gastric emptying. 30-32 In contrast, individuals with BED and obesity do not differ in postprandial CCK responses from those with obesity but no BED. 33 The relationships between CCK, binge eating, and BMI warrant further clarification. Peptide tyrosine, PYY, the intestinally derived anorexigen that elicits satiety, appears to be dysregulated in individuals with an NBN, but not in those with BED. Young women with an have higher levels of PYY compared with controls, perhaps contributing to reduced food intake. 34, 35 in individuals with BN, expected elevations in PYY after meals are blunted. 36, 37 possibly playing a role in impaired satiety. A recent report found no differences between bed and non-bed groups in fasting levels and postprandial changes in PYY. 38 women with BN have been found to secrete abnormally low levels of the GI satiety peptides glucagon-like peptide 1 and pancreatic polypeptide, which is thought to be a consequence of the adaptation to large meals in the form of enlarged gastric capacity and reduced muscle tone in the gastric wall. Attenuated secretion of these GI satiety polypeptides may play a role in maintaining bulimic behavior. 39 Appetite. The orexigenic peptide ghrelin is of interest in EDS because it is the only known GI hormone that stimulates appetite and promotes food intake. 40 Ghrelin influences secretion of growth hormone, induces adiposity, and is implicated in signaling the hypothalamic nuclei involved in energy homeostasis. Gastric secretion of ghrelin is stimulated by a combination of neural, vagus nerve, mechanical, distension, chemical, osmolarity, caloric content and macronutrient composition of the meal, and hormonal, insulin, factors with unknown priority. 41 Consistent findings in the literature examining ghrelin in patients with AN have shown that 1. Circulating basal levels of ghrelin are elevated, a likely consequence of prolonged starvation. 40, 42, 43, 2. Growth hormone and appetite responses to ghrelin are blunted, suggesting ghrelin resistance or altered ghrelin sensitivity. 41, 44, 45, and 3. Ghrelin levels return to normal after partial weight recovery, suggesting a physiologic effect to compensate for lack of nutritional intake and energy stores. 40, 46 More recently, a randomized, double-blind, placebo-controlled trial using a ghrelin agonist in 22 outpatients with AN revealed that those treated with a ghrelin agonist demonstrated significantly decreased gastric emptying time, and a trend of greater weight gain after 4 weeks. 47 Plasma levels of ghrelin are normal or elevated in individuals with BN, which suggests that abnormal eating behaviors, including binge eating and purging, may influence ghrelin secretion. 36, 37 There is a postprandial blunted response, i.e., reduced suppression of ghrelin, in these patients. 48 The relationship between elevated ghrelin and binge eating in patients with BN requires further exploration. 46 Investigations of ghrelin functioning in individuals with BED have reported lower circulating levels of pre- and postprandial ghrelin, possibly reflecting downregulation in response to chronic overeating and smaller decreases in ghrelin after eating. 38 Energy storage. Leptin and adiponectin are hormonal signals associated with longer-term regulation of body fat stores. Leptin is also directly implicated in satiety through its binding to the ventral medial nucleus of the hypothalamus, an area termed the satiety center. Leptin and adiponectin are both altered in patients with EDS. A number of studies have found evidence for hyperadiponectinemia and hypoleptinemia in populations of underweight and with reversal following restoration of weight. 49, 50. Increased adiponectin levels may act protectively to support energy homeostasis during food deprivation. Individuals with BN also exhibit decreased plasma levels of leptin and increased levels of total Chapter 9 feeding and eating disorders 119.9 plasma adiponectin, which are inversely correlated with longer duration of illness and increased severity of symptoms. 51, 52 The mechanism of altered leptin functioning in BN is unclear because blunted postprandial leptin levels are not observed in individuals with BED. 33 There are other mechanisms of interest including neuropeptide Y, peptides, glucagon-like peptide 2, orexins A and B, the endocannabinoids, resistin, adipose tissue-specific secretory factor, and brain-derived neurotrophic factor, but more research is necessary to elucidate their roles in the pathophysiology of EDS. One high priority for research is clarifying whether observed psychobiological abnormalities are antecedents or consequences of disturbed eating behavior that return to normal after recovery. This information could shed light on cause and possible treatment targets. Patients often report intense discomfort after eating as a reason they continue to restrict intake. The discomfort may be dismissed as perceptual or psychological in the absence of any medical findings to support the symptoms, but there may be disruptions in CNS or peripheral signals contributing to this and other reported symptoms. Onset and course in NBN most commonly have their onset in adolescence. 53 and BED usually manifests in the early 20s. 54 but EDS can occur throughout most of the lifespan and appear to be increasing in frequency in middle-aged and older women. 55. 56 Diagnostic migration from one ED category to another is common. 57 ARFID most commonly has its onset in the early years but can continue into adulthood. 1 Pica has been described in both children and adults, but little is known about the courses of pica and rumination disorder. 15 Lifetime comorbidity of NBN and BED with other psychiatric disorders has been reported as high at 56.2%, 94.5%, and 63.6%, respectively. 58 Mortality associated with an NBN combined is 5 times higher than expected and is one of the highest mortality rates among mental disorders. 2 Some data support the chronicity of an, reporting that slightly less than half of survivors with an make a full recovery, with 60% attaining a normal weight, and 47% regaining normal eating behavior, 34% improve but only achieve partial recovery, whereas 21% follow a chronic course. 59 Other data suggest that recovery rates for an may be more favorable than previously believed. 58 With a large twin cohort study reporting a 5-year clinical recovery rate of 66.8%. 60 In contrast, after a 5-year follow-up of 216 patients with BN and EDNOS, 74% and 78% of patients, respectively, were still in recovery. 61 In a 6-year longitudinal study of patients with BED, 43% of individuals continued to be symptomatic. 62 A recently published 22-year longitudinal study of patients with an NBN demonstrated that the presence and persistence of binge eating and purging behaviors were poor prognostic indicators to overall recovery and that comorbidity with depression at initial assessment strongly predicted the continuation of an at the 22-year mark. 63 In summary, despite decades of studies that have investigated potential treatment modalities for the EDS, up to 50% of treated individuals continue to be symptomatic in follow-up. 64 Evaluation A substantial percentage of individuals with an ED in the U.S. do not receive specific treatment for this problem. 58 Despite clear diagnostic criteria for EDS, clinical detection is often problematic, and up to 50% of cases may go unrecognized in clinical settings. Moreover, individuals with EDS are often reluctant to disclose their symptoms. 65 Although individuals with an are underweight by definition, this can be easily missed in clinical settings. Even when noted on evaluation, the medical seriousness of low weight frequently is unappreciated. 66 When an ED is suspected or confirmed, patients may decline or avoid medical or mental health care, and a feature of an can be denial of the medical seriousness of symptoms. 11 Therefore, ascertainment of concerns about body shape, weight, fatness, and weight gain or loss can be especially challenging when patients are unable or unwilling to recognize or to disclose them. 67 Given that many individuals with EDS initially present in primary care or medical subspecialty settings, recognition of clinical signs and symptoms across diverse healthcare settings will facilitate appropriate referrals and make diagnostic evaluation and treatment plans more efficient. One study has reported that individuals with BN are more likely to seek help for their GI complaints before seeking treatment for their ED. 68 Familiarity with the diagnostic features and GI complications of eating disorders will help the clinician identify the most appropriate interventions, including the full spectrum of treatment resources available for a comprehensive treatment plan. When an ED is suspected, a directed clinical interview about restrictive or binge eating and inappropriate compensatory measures to control weight, Box 9.1, is essential in determining the scope and severity of symptoms that underlie specific GI complaints and pose medical risk. Accurate and timely diagnosis of EDS is challenging for several reasons. First, patients may be unreliable reporters of their history, and BN and BED may be present without any abnormal physical findings, as may pica and rumination disorder. In addition, some dietary modifications and exercise behaviors certainly are appropriate, and discerning pathologic behavior that is consistent with a clinically significant ED can be difficult. There is considerable overlap in symptoms among the EDS, diagnostic specificity, however, is critical to effective management. Given the frequent reluctance of patients to recognize or to disclose symptoms of an ED, targeted history taking may be essential to making a prompt diagnosis. In some cases, an ED may not be suspected or the diagnosis confirmed until physical findings suggestive of purging are detected, a suggestive pattern is noticed in weight changes, or there is difficulty gaining weight notwithstanding appropriate nutritional treatment and exclusion of other potential causes for low weight. Diagnosis of specific disorders. Anorexia nervosa and is characterized by a significantly low weight, the weight that is less than minimally normal, fear of gaining weight, despite being thin, and a disturbance in the way body shape or weight is perceived, e.g., a denial of the medical seriousness of being underweight or feeling fat despite emaciation. 1. It is not uncommon for Box 9.1 behaviors used to compensate for excessive food intake or to prevent weight gain. Purging behaviors: diuretic abuse, laxative and/or enema abuse, self-induced vomiting, including syrup of ipecac abuse, non-purging behaviors, excessive physical activity, fasting, skipping meals, restrictive eating pattern, inappropriate withholding or underdosing of insulin, among individuals with diabetes mellitus, stimulant abuse, e.g., caffeine, ephedra, methylphenidate, cocaine. 120 Part 2 Nutrition in gastroenterology: an individual within to deny or minimize fear of weight gain at initial evaluation, and sometimes an apparent absence of this fear persists. Point 69 Even if a patient does not admit or disclose an intense fear of weight gain, evidence of continuing behaviors that undermine weight gain, e.g., restrictive eating, purging, excessive exercising, may be used to establish this criterion. Individuals within typically restrict their food selections and caloric intake, but about half of those within also routinely binge eat and/or engage in inappropriate purging behaviors like self-induced vomiting or laxative used to prevent weight gain. Box 9.1. And is further divided into two subtypes: restricting type, those who primarily control their weight through dieting, fasting, or exercising, and binge eating/purging type, those who routinely purge calories to control weight and/or routinely binge eat. Point 1 In middle-aged and older women, new onset and may present in conjunction with difficulty making life transitions and fear of aging. Point 56 The diagnosis of an may be delayed when patients present to a GI specialty practice without disclosing their concerns and behaviors relating to weight. Presentation with GI complaints, even if related to real symptoms or disease, can sometimes prove to be a red herring, drawing attention away from and delaying diagnosis of an ED. One study of 20 consecutive patients who presented to a GI practice and ultimately were diagnosed with an ED found the diagnosis of an ED was delayed for an average of 13 months after presentation. Notably, all patients stated a desire to gain weight and denied attempts to lose weight via exercise, purging, or dietary restriction. 70 Individuals within are not always able or willing to frame their difficulty maintaining a healthy weight as intentional, so diagnosis may initially be unsuspected and delayed. Bulimia nervosa: the clinical hallmark of BN is recurrent binge eating accompanied by inappropriate compensatory behaviors to control weight or to purge calories consumed during a binge. See Box 9.1. On average, these behaviors must occur once each week for at least 3 months to meet diagnostic criteria. Point 1 Also intrinsic to the diagnosis of BN is the excessive influence of weight and/or shape on self-image. Individuals with BN have poor self-image that is often anchored to their weight. It is not unusual for individuals with an ORBN to weigh themselves daily, even several times each day, and to experience fluctuations in self-esteem and mood based on the result. By definition, binge eating is consumption of an unusually large amount of food during a discrete period of time, i.e., not overeating or grazing all day, accompanied by the feeling that the eating cannot be controlled. Point 1 Many patients describe an emotional numbing during the period of eating. For some, this state appears to motivate the binging. Most clinicians are familiar with self-induced vomiting as the primary purging behavior, but individuals with BN may also use alternative or additional means to prevent weight gain, including abuse of laxatives and/or enemas, diuretics, stimulants, including methylphenidate, cocaine, over-the-counter natural supplements, and caffeine, underdosing of insulin, for those with diabetes mellitus, fasting or restrictive eating, and excessive exercise, see box 9.1. In adolescents with celiac disease, intentional consumption of gluten to promote weight loss has also been reported. 71 Whereas most individuals with BN use compensatory behaviors that include purging, those who only use excessive physical activity or fasting are more challenging to identify. As with overeating and dieting, it is frequently difficult to determine the line between culturally normative and pathologic behavior with excessive exercise. Generally, clinical suspicion should be raised when an individual continues to exercise despite an injury or illness, or if he or she is exercising routinely in excess of what a coach is advising for the team. It is recommended that clinicians ask about purging behaviors if an ED is suspected. Although it is not certain that a patient will respond candidly, individuals are more likely than not to eventually disclose information about symptoms when asked. 65 Some patients report feeling relieved when clinicians pose such questions if they previously had not been able to discuss their symptoms. On occasion, however, patients report learning about techniques from clinicians' questions, so it is advisable for clinicians to provide a psychoeducational context for the questions, e.g., by conveying serious physical consequences associated with the behavior, and to avoid introducing information about a dangerous behavior, e.g., underdosing insulin, using appropriate discretion based upon the clinical context. Patients also benefit from learning that treatment is available and effective, and from feeling understood by their clinicians. Whereas purging and other behaviors aimed at neutralizing or decreasing calorie intake and modifying weight can pose medical risks when chronic, some of them pose more immediate and potentially lethal consequences. Patients should be educated about these acute life-threatening risks, and steps should be taken to eradicate such behaviors immediately. For example, because of the serious neurotoxicity, cardiotoxicity, and risk of death associated with repeated ingestion of syrup of ipecac 72, its ongoing use is a clinical emergency and may require immediate hospitalization. Many patients are unaware of the serious risk associated with syrup of ipecac use. Similarly, ephedra, now banned in the US, poses risk of stroke or adverse cardiac events even in young adults. 73 Some ephedra-free supplements marketed as weight loss agents may also be pro-arrhythmic and pose medical risks. 74 Although patients find it difficult to abstain from purging behaviors, they may be willing to substitute less immediately harmful behaviors while treatment is initiated. Binge eating disorder BED is characterized by recurrent and persistent binge eating. To meet diagnostic criteria, binge episodes should occur at least weekly, on average, over a duration of 3 or more months. Unlike BN, BED is not associated with recurrent inappropriate compensatory behaviors to prevent weight gain. BED is distinguished from non-pathologic overeating by several possible associated symptoms including rapid eating, eating irrespective of hunger or satiety, eating alone because of shame, and negative feelings after a binge. 1 Apart from overweight or obesity, which is common in BED patients frequently present without any specifically associated physical findings. Although in some cases binge eating associated with BED may cause or perpetuate weight gain, many with BED develop symptoms only after they have become overweight. Individuals with BED are frequently distressed enough about their symptoms to seek medical help, although they may present seeking a solution to their weight gain rather than their binge eating. A substantial percentage of patients who seek weight loss treatment will have comorbid BED. Therefore, medical subspecialists are likely to encounter these patients before they have been diagnosed with BED. Other specified feeding or eating disorder and unspecified feeding or eating disorder (OSFT and USFT) comprise presentations that fall short of criteria for one of the major feeding or EDS, but are nonetheless clinically important because of distress or impairment, including serious medical consequences. OSFT is used when the reason for not meeting full syndrome criteria is specified, including 4 presentations named in the DSM-5, and USFT is used when the reason is left unspecified. In addition to a variety of ways a patient can present with clinically significant symptoms that still do not meet the threshold for one or more diagnostic criteria, Chapter 9 Feeding and Eating Disorders 121-9 There are several named symptom presentations with provisional descriptions. These include atypical AN, subthreshold BN, subthreshold BED, night eating syndrome, NES, and purging disorder, PD. 3 of the OSFT variants are characterized by failure to meet full syndrome criteria for an, BN, or BED in the presence of the other criteria, as well as clinically significant distress or impairment. Atypical AN is a form of subthreshold AN, characterized by a fear of fatness and body image disturbance in the absence of low weight. For example, some individuals with a history of obesity lose a substantial amount of weight, e.g., following gastric bypass surgery, and while still in a normal weight range also manifest an extreme fear of weight gain and body image disturbance. 1 Subthreshold BN and BED are also OSFT variants. They are each characterized by meeting all criteria for BN or BED, respectively, except for frequency or duration. An individual with recurrent binge eating that occurs monthly but not weekly, in the presence of all other diagnostic criteria for either BN or BED, would meet criteria for OSFT if clinical impairment and/or distress were present. 2 other notable OSFT variants are NES and PD. First described in 1955-75, NES is characterized by recurrent bouts of evening or nocturnal overeating but not necessarily binging without associated inappropriate compensatory behaviors to prevent weight gain. There has been no clear consensus on core criteria for NES, although investigators have proposed morning anorexia, evening hyperphagia, e.g., consuming a disproportionately large number of calories in the evening or after dinner, and sleep disturbance, operationalized in various ways including difficulty falling or staying asleep. Some have proposed the additional criterion of eating in relation to sleep disturbance, such as during a nighttime awakening. 76 Given the insufficient research on operational criteria, prevalence, course, and differentiation from other EDS, NES still lacks a formal definition. 77 In the DSM-5, NES is described by recurrent evening or nighttime eating an individual is aware of, and not due to a medical, pharmacologic, or social contextual cause. As with other OSFT variants, the condition must be associated with clinically significant impairment or distress and cannot be better described by a different ED like BED or BN. 1 In one study, NES in obese study participants was associated with an average of 3.6 awakenings/night compared with just 0.3 awakenings/night for matched controls. Available data suggest that individuals with NES consume considerably fewer calories during their nocturnal eating episode compared with the usual intake of a binge associated with BN or BED. 78 NES can also occur in non-obese individuals 79 but is more common in the obese and may contribute to poor outcome in weight loss treatment programs. 78 ADPD, another OSFT variant, is characterized by recurrent purging symptoms in the absence of clinically significant binge pattern eating. Like the other EDS, PD is more common among women than men, but peak onset, at age 20, appears to be later than for BN. 81 Lifetime prevalence of PD has been estimated as 1.1% to 5.3% of young adult women. Course, outcome, and treatment strategies for PD require further research. 82 Avoidant/restrictive food intake disorder previously encompassing feeding disorder of infancy or early childhood in the DSM-4. 11 ARFID was introduced into the nomenclature in the DSM-5 and its former criteria adjusted to include a wider variety of presentations. 83 ARFID is a diagnosis that can occur across the lifespan. The signature feature of ARFID is a disturbance in eating or feeding that yields significant nutritional or psychosocial compromise and/or requires special feeding measures, e.g., dietary supplements to correct a nutritional deficiency or enteral feeding to supply calories. The food intake disturbance often results from sensory-based avoidance, feared consequences of eating associated with aversive experiences, or lack of interest in eating. The disturbance cannot be ascribed to an or a medical condition unless the nutritional deficit for the latter is more severe than would normally be expected and requires additional clinical measures. ARFID can be comorbid with neurodevelopmental disorders, such as intellectual disability and autism spectrum disorder. For the latter comorbidities, ARFID is more common among males compared with those who have an ORBN. The nutritional deficits associated with ARFID may have an adverse impact on growth, development, and learning. 184 It is important to note that the diagnosis of ARFID covers a range of different clinical presentations. To diagnose ARFID, the clinician must elicit a comprehensive history to determine food intake with respect to range and amount, and also to establish whether the nutritional deficits are associated with weight loss, failure to gain weight as expected, or faltering growth, clinical or laboratory abnormalities, dependency on nutritional supplements or tube feeding, or interference with the individual's social and emotional functioning. 84 Pica is a disorder characterized by recurrent and persistent ingestion of non-food substances like chalk, paper, paint chips, or laundry starch. Pica eating that is developmentally normal, e.g., an infant eating dirt, does not warrant a diagnosis of pica, although it may require clinical intervention. When pica eating is socially normative or culturally sanctioned, it does not meet criteria for a diagnosis of pica. Pica is the only feeding or ED that can co-occur with another feeding or ED. Each of the other EDS is mutually exclusive with other feeding and EDS. Rumination disorder. The hallmark of rumination disorder is repeated and persistent, over at least 1 month, effortless, voluntary regurgitation that is not solely attributable to a medical condition. Gastric contents that are brought up are sometimes spit out, but alternatively may be rechewed and or swallowed. Regurgitation is sometimes used for self-soothing or self-stimulation. The prevalence of rumination disorder is unknown, but it can occur in both children and adults. 15 Rumination disorder is superseded by a diagnosis of an ORBN, although the behavior may be superimposed on other symptoms. Differential diagnosis. Differential diagnosis of the EDS includes evaluation and exclusion of medical causes of weight loss, weight gain, anorexia, hyperphagia, vomiting, and other associated symptoms. These considerations are especially germane in cases of atypical presentations, or early or late onset EDS. 56 Occasionally, EDS can be mistaken for a medical condition, or a medical condition can be misdiagnosed as an ED. Individuals with a medical condition that is associated with loss of weight or appetite, however, will often express concern over their weight loss and changes in their body weight, shape, and size, whereas this is not the case in individuals with an. Individuals with ARFID may express concern or distress about their poor appetite or nutrition. Medical causes of appetite and/or weight loss include hyperthyroidism, Addison disease, diabetes mellitus, malignancy, IBD, malabsorption, immunodeficiency, infectious diseases, e.g., TB, HIV, collagen vascular disease, substance abuse, mood and anxiety disorders, dementia, delirium, and psychosis, see chapters 35 and 37. Food allergy or intolerance, as well as other GI diseases that can cause discomfort with eating, should be excluded in patients with presentations consistent with ARFID. 1 Illnesses associated with weight gain include hypothyroidism, Cushing disease, and organic brain disease. 122 Part 2 Nutrition in gastroenterology. The differential diagnosis of hyperphagia is broad and includes Prader-Willi syndrome, dementia, including Alzheimer's disease, and intracranial lesions. Hyperphagia has also been associated with the use of certain medications, particularly many of the psychotropic agents, e.g., lithium, valproate, tricyclic antidepressants, mirtazapine, conventional and atypical antipsychotic agents, pregnancy. 85 and post-starvation refeeding. 86 The regurgitation associated with BN, rumination disorder, and PD, and sometimes AN, is volitional, and is therefore distinctive from GERD or vomiting with nausea. 15 Psychiatric illnesses associated with loss of appetite and weight loss include major depression, anxiety, and substance use disorders. Moreover, comorbid psychiatric illness is common among those with EDS 5/8 and frequently complicates their diagnosis and treatment. Thus, identification of excessive concern with weight and food intake, unrealistic or inappropriate weight goals, or resistance to attempts to restore normal weight and/or limit excessive exercise can be helpful in distinguishing it from another psychiatric illness or revealing the presence of an underlying comorbid ED. Because individuals with BN, BED, OSFT, and USFT can have an unremarkable physical examination on presentation, the diagnosis may remain obscure until the patient discloses his or her symptoms, or until the clinician suspects an ED based on other elements of the clinical history or course, weight fluctuations, menstrual irregularities. Even though a trans-diagnostic approach to treatment of EDS has been proposed, in which management focuses on common maintaining mechanisms across the EDS-87, there is evidence of differential response to treatment across the EDS, and it is desirable to establish a clear diagnosis to optimize treatment effectiveness. Although there is a great deal of phenomenologic overlap among the EDS and individuals do cross over from one diagnostic category to another, Table 9.1, 57 categories are mutually exclusive according to the DSM-5 diagnostic criteria. Point 1. The exception to this rule is pica, which can co-occur with another ED. Generally, a diagnosis of AN will take precedence over all other feeding and ED diagnoses, and BN will supersede all other diagnoses with the exception of AN. A low-weight criterion distinguishes AN from BN in some cases. Individuals who are substantially underweight and otherwise meet criteria for AN most likely should be classified as having AN even if binging, purging, or both are present. AN and ARFID both present with nutritional compromise, although in ARFID this can manifest as either low weight, not meeting weight expectations, faltering growth, or a nutritional deficiency, and individuals with ARFID lack body image disturbance and fear of fatness. Individuals with BED or BN can also have symptom overlap. BN is distinguished by recurrent purging and other behaviors directed at neutralizing excessive calorie intake so as to prevent weight gain, as well as an excessive concern with weight. Regurgitation associated with rumination disorder can be difficult to differentiate from purging associated with BN. Although the so-called vomiting associated with rumination disorder is volitional, it is also effortless in contrast to the purging that typifies BN, so is not by definition vomiting. Patients and occasionally healthcare providers often mistake the two occurrences. Unlike AN and BN, rumination disorder is not associated with either body image disturbance or excessive weight or shape concerns. OSFT and USFT diagnoses are reserved for individuals who do not meet full syndrome criteria for one of the major feeding or EDS, but nonetheless have associated clinically significant impairment or distress. For example, a normal or overweight individual who has an intense fear of weight gain and body image disturbance does not meet criteria for AN but rather for atypical anorexia. Individuals who are of normal weight and have recurrent purging, but no binging, would likely be classified as having PD. Normal or overweight individuals with recurrent nighttime overeating but neither binge eating nor purging would likely be given a diagnosis of NES. Table 9.1 Distinguishing features of feeding and eating disorders. Feeding or eating disorder. Physical signs included in diagnostic criteria: restrictive pattern eating, binge pattern eating, purging and other behaviors to control weight or neutralize effects of caloric intake, excess concern with body image or weight, and significantly underweight typically may occur. Purging may occur in up to 1/2 of patients. Yes, ARFID. Significantly underweight or other nutritional deficiency typically may include not eating enough, avoidance of certain kinds of food due to sensory features, fear of food due to a traumatic eating experience, e.g., gagging, choking, or being indifferent to food. No BED. None. Patients are frequently overweight or obese. No must occur an average of once per week for at least 3 mo. No yes BN. None. Patients are generally normal weight or overweight, may occur as behavior to control weight. Must occur an average of once per week for at least 3 mo. Must occur an average of once per week to meet diagnostic criteria. Yes pica. No rumination disorder. No voluntary regurgitation occurs but is not intended to purge calories. No anorexia nervosa, ARFID, avoidance/restrictive food intake disorder, BED, binge eating disorder, BN, bulimia nervosa. Data from American Psychiatric Association. Diagnostic and Statistical Manual of Mental Disorders. 5th ed. Arlington, VA, American Psychiatric Association, 2013. Chapter 9 Feeding and Eating Disorders 123 Nutritional, Medical, and Laboratory Evaluation 9 In addition to excluding medical and psychiatric causes of weight and appetite change, medical evaluation for confirmed or suspected EDS includes obtaining a full history of the patient's eating behaviors and symptoms with attention to the number of calories ingested daily, purging behaviors, e.g., vomiting or laxative use, diuretics, diet pills, ipecac, complementary and alternative medications. See Chapter 131, and Exercise Patterns. Often, medical evaluation will be guided by an assessment of nutritional status that includes determining appropriateness of weight for height, age, and gender. Nutritional evaluation: a detailed dietary history that includes an individual's 24-hour dietary recall can provide insight into caloric intake and quality of nutrition. The clinician should also explore the patient's beliefs about, and attitudes and behaviors toward, eating, food, weight, and health. The types of foods and beverages consumed to reduce hunger, e.g., caffeinated coffee, tea, diet soda, portion sizes, diet products used, calorie and fat intake, low-fat or fat-free foods consumed, and foods the individual considers forbidden, or bad, and safe, or good, should be assessed. Some individuals report undiagnosed food allergies, gluten sensitivity, or lactose intolerance. Such concerns should be investigated as clinically indicated. The clinician should ask about vegetarianism and the patient's reasons for becoming a vegetarian. Individuals with an ED may weigh themselves frequently, sometimes several times each day. People with an may wear large, baggy clothing as a consequence of their body image distress, or to hide their weight loss from others. For individuals who binge, there may be disappearance of large quantities of food. For those who purge, they may exhibit frequent trips to the bathroom, especially after meals. Individuals with EDS may display a number of behaviors and food rituals, including cutting food into tiny pieces and moving it around their plate, chewing food and spitting it out, taking small bites, eating the same foods daily, and taking a long time to complete meals. It is not uncommon for individuals with EDS to cook for others but not eat any of the food prepared. A history of ingesting non-food substances is essential in evaluating pica and will often require collateral history from a parent or caregiver. Avoidance of eating, as seen in patients with ARFID, can be associated with a history or fear of aversive consequences of eating, e.g., precipitated by a history of vomiting or a traumatic GI or other medical study. Point 1. Special considerations in the determination of weight and weight status. There are several established means for evaluating the nutritional status of patients with EDS in the office, central to which is measuring weight and height and calculating the BMI. See Chapter 5. Assessment of the appropriateness of weight for height is a key factor intrinsic to determining the urgency of medical and psychiatric care. For patients with an, it is critical to not rely on self-reported weight, given the strong possibility of an inaccurate report. Individuals with an may sometimes go to great lengths to conceal their low weights, some water load prior to a clinical encounter, some attach or hide weights to one's body, and others layer loose and bulky clothing to create the illusion of being of normal weight. Assessment of weight, therefore, should factor in the possibility that a patient may wish to conceal a low weight or weight loss. Clinicians should consider having a scale in a private area, e.g., not in a hallway, and a clear and consistent protocol for weighing patients within. This might include asking patients to void prior to being weighed, change into a hospital gown, and remove heavy jewelry. When patients have a history of consuming water prior to an appointment to increase their measured weight, it may be helpful to check a urine-specific gravity and electrolytes. Hyponatremia may occur in individuals with excessive water intake or those who water load. 88-90 Standard means of evaluating the appropriateness of weight for height in adults includes the use of BMI, which is calculated using the following equation: BMI equals weight, in kg, height, in m2. Although BMI may not be an appropriate standard to determine the health of weight status in all individuals, e.g., those who have relatively high lean muscle mass, certain ethnic groups, 91 BMI is generally considered a first-line assessment measure for most men and women aged 18 or older. BMI of 18.5 to 24.9 kg/m2 for men and women is considered normal. BMI of 17.5 kg/m2 or less meets the underweight criterion for an in the ICD-10, International Classification of Diseases 10, 11,92. BMI of 25 to 29.9 kg/m2 is consistent with overweight. and BMI over 30 kg/m2 reflects obesity. 93 Interpreting the severity of a low weight in adults will incorporate both the absolute BMI criterion, e.g., BMI 15 kg/m2 is given by the DSM-5 for extreme severity, 1 and the clinical context. That includes both weight history and medical complications. A number of other methods are routinely used to calculate % of expected body weight for adults. One of the more widely used equations to calculate expected body weight in adults is, expected body weight, % equals patient weight expected weight for height and gender times 100%. Although this is a linear equation, compared with the quadratic equation for BMI, and may be less useful at extreme heights, it is straightforward to calculate. Moreover, this formula may be conceptually easier for patients and families to understand, especially in setting weight goals or limits. A weight within the range from 90% to 110% of expected body weight will likely be considered normal and is a good place to begin for setting weight gain goals for patients within this range. The goal will be refined by clinical history, including the patient's history of baseline, minimal, and maximal weights, whether and when menses return, and medical parameters like reversal of bone loss. For patients who are overweight or obese, 110% or 120% expected body weight, respectively, it may not always be realistic or desirable to set weight goals within the normal BMI range. Patients who are severely nutritionally compromised may require inpatient care for both efficacy and safety of weight management. For underweight patients without this degree of compromise, the primary goals of nutritional management are increasing caloric requirements to regain weight, ensuring adequate intake and balance of macro and micronutrients, and re-establishing a dietary pattern of 3 meals and 1 to 3 snacks daily. In such cases, consultation with experienced ED practitioners regarding optimal refeeding and treatment support strategies should be strongly considered. Patients may also be supplemented with calcium, if dietary intake is inadequate, vitamin D, and/or multivitamins. Some patients may require additional dietary guidance, adjustments, and supplementation because many restrict not only calories but specific foods or food groups as well. For patients with BN, BED, and sub-threshold BN and BED encompassed by OSFT, dietary intervention includes moderating excessive caloric intake and establishing a pattern of eating that is less vulnerable to emotional cues and excessive. 124 Part 2 Nutrition in Gastroenterology. Hunger. Many patients with EDS are quite knowledgeable about nutrition and commonly wish to avoid meeting with a dietitian, but information from a nutritional assessment is invaluable to the treatment team. Even well-informed patients are likely to benefit from reinforcement of more healthful food choices, meal patterns, and appropriate intake. Medical evaluation. The goal of the medical evaluation is to obtain information that will be helpful in formulating a diagnosis, evaluating the acute and long-term medical and psychiatric consequences of the feeding or ED, and determining a comprehensive treatment plan. Medical evaluation includes a clinical history with special attention to weight loss, weight fluctuations, and any binging, purging, or other inappropriate behaviors that affect or aim to control weight. See Box 9.1. Symptoms of medical complications of undernutrition, overnutrition, binging, purging, and excessive exercise should be assessed, and a complete menstrual history should be clarified. Physical examination includes a comprehensive assessment of potential complications of low, excessive, or unusual dietary intake, as well as nutritional deficiencies, underweight, overweight, excessive exercise, and purging behaviors. If an ED is suspected, physical examination may reveal signs that confirm nutritional compromise, e.g., bradycardia, hypotension, hypothermia, lanugo hair, breast tissue atrophy, muscle wasting, peripheral neuropathy, or suggest chronic purging, e.g., Russell sign excoriation on the dorsum of the hand incurred during self-induced vomiting from chronic scraping against the central incisors, hypoactive or hyperactive bowel sounds, an attenuated gag reflex. 94 Tooth enamel erosion. Perimyelitis, 95 or parotid hypertrophy. 96 Medical complications of behaviors associated with all feeding and EDS are potentially serious and too numerous to review in detail here, Selected complications are listed in Table 9.2. Complications that are common and/or associated with serious morbidity should be actively sought on physical examination and laboratory studies so that appropriate interventions can be initiated. Examples of important and common findings include abnormal vital signs, e.g., hypotension, orthostatic changes in blood pressure and/or heart rate, bradycardia, hypothermia, low weight or overweight, dental pathology, e.g., perimyelitis, dental caries, or both, 96-98, and osteopenia or osteoporosis. 99 Cardiac complications can be lethal and include prolonged QT interval, QT dispersion, ventricular arrhythmias, and cardiac syncope. 100, 101 Neurologic findings in and include cortical atrophy and increased cerebral ventricular size. 102 Endocrinologic abnormalities include menstrual disorders, low serum estradiol levels, low serum testosterone levels, hypercortisolism, and euthyroid 6 syndrome, with resultant hypotension and cold intolerance. 103 Heavy metal toxicity is a potentially serious complication of pica. 5, 104 Intentional omission of insulin by individuals with type 1 diabetes for the sole purpose of inducing weight loss can also pose considerable risk. Similarly, some individuals with type 2 diabetes intentionally omit oral hypoglycemic agents, resulting in poor glycemic control and weight loss. Clinical signs that should raise suspicion include poor glycemic control, recurrent episodes of diabetic ketoacidosis, missed clinical appointments, poor self-esteem, and dietary manipulation. 105 The diagnosis of both an ED and diabetes, coupled with intentional omission of insulin use, is associated with higher glycosylated hemoglobin levels, increased episodes of hypoglycemia and resulting hospitalizations for diabetic ketoacidosis, growth retardation, and pubertal delay in adolescence, and increased microvascular complications. 106, 107 Reported complications of ED during pregnancy include miscarriage, inadequate weight gain of the mother, intrauterine growth restriction, premature delivery, infants with low birth weight and low APGAR scores, and perinatal death. 108-111 Laboratory evaluation. Laboratory evaluation should be done at the time of the initial assessment to rule out other medical illnesses and assess for acute metabolic derangement. Not uncommonly, a malnourished individual within will have normal laboratory results, although those who actively binge and purge may exhibit a number of metabolic abnormalities. 107 Laboratory investigations should be performed during nutritional rehabilitation to monitor for a variety of serious and life-threatening metabolic, cardiovascular, and neurologic abnormalities that can occur as a result of refeeding. See Chapters 5 and 6. 112 The choice of laboratory studies to evaluate medical complications of EDS will depend on the clinical history, presentation, and degree of malnutrition. For patients with an, a complete blood cell count is recommended during initial assessment to assess for anemia, neutropenia, leukopenia, and thrombocytopenia. A retrospective study of 67 patients with an found that 27% had anemia, 17% had neutropenia, 36% had leukopenia, and 10% had thrombocytopenia. 113 It is useful to obtain serum electrolyte levels for individuals in whom an ORBN is suspected or confirmed. Hypokalemia occurred in 4.6% of a large number of outpatients with EDS in one STUDY 114 and in 6.8% of individuals with BN in another moderately sized cohort 115. In the latter study, hypokalemia was significantly more common in patients with BN than in those without it. Although assessment for hypokalemia may not identify occult cases of BN, it will help identify and monitor individuals at risk for cardiac arrhythmias secondary to their ED. Hypochloremia, hypomagnesemia, hyponatremia, hypernatremia, and hypophosphatemia are also seen in patients with EDS. 106, 107, 115 to 117 For patients with an, a serum glucose determination is recommended to identify hypoglycemia, which can be severe in this population. 118 Although hyperamylasemia is seen in 25% to 60% of patients with BN, laboratory analysis of serum amylase is generally not clinically useful for detecting BN or gauging the severity of binging and purging symptoms. 119 Elevated serum amylase level in a patient with an ORBN often reflects increased salivary isoamylase activity 119, 120, but pancreatitis should be considered when clinically appropriate, given its occurrence in this patient population. Renal and liver biochemical testing and urinalysis should also be considered. If pica is suspected, testing serum for evidence of heavy metal toxicity, e.g., lead, mercury, copper, zinc, is appropriate. In women with amenorrhea, evaluation of the cause is suggested, even if it is presumed to be related to decreased pulsatility of gonadotropin-releasing hormone secondary to weight loss. 103 Menstrual irregularities are common among women with EDS, but women with symptomatic EDS may continue to menstruate at presentation. 121 And women with AN can become pregnant. 122 A quantitative beta-human chorionic gonadotropin and possibly a serum prolactin level are therefore recommended. Additional studies such as follicle-stimulating hormone to evaluate ovarian function or neuroimaging studies to exclude a pituitary lesion may be indicated in some clinical scenarios. Bone densitometry using dual-energy X-ray absorptiometry scans of the hip and spine are useful in identifying bone loss and can be repeated after a year to assess further bone loss if disease continues. Osteopenia and osteoporosis may be present in as many as 90% and 40%, respectively, of women with AN and are associated with risk of fractures and kyphosis. 99, 123 A baseline electrocardiogram is also recommended and can identify corrected QT, QTC, prolongation, patients with AN. 124 and prolongation of the QTC interval even in the absence of hypokalemia, patients with BN and EDNOS. 125 Some antipsychotic agents and tricyclic antidepressants can cause QTC prolongation, which can lead to torsades de pointes and sudden death. As such, careful selection of psychotropic medications and identification of a patient's risk for QTC prolongation should be Chapter 9 Feeding and Eating Disorders. 125 Table 9.2 Selected clinical features and complications of behaviors in patients with eating disorders. * 9 System-affected clinical feature or complication associated with weight loss and food restriction or binge eating in anorexia nervosa or OSFT/USFT associated with purging or refeeding behaviors in anorexia nervosa. Bulimia nervosa, or OSFT/USFT cardiovascular arrhythmia bradycardia chest pain decreased cardiac size diminished exercise capacity dyspnea edema heart failure hypotension mitral valve prolapse orthostasis palpitations prolonged QT interval QT dispersion syncope cardiomyopathy, with ipecac use, chest pain edema orthostasis palpitations prolonged QT interval syncope ventricular arrhythmia dermatologic acrocyanosis brittle hair and nails dry skin hair loss. Hyperkeratonemia Lanugo-Russell sign, knuckle lesions from repeated scraping against incisors, endocrine and metabolic amenorrhea and oligamenorrhea euthyroid 6 syndrome hypercholesterolemia hypocalcemia hypoglycemia hypomagnesemia hyponatremia hypophosphatemia hypothermia low serum estradiol, low serum testosterone levels osteopenia, osteoporosis pubertal delay, arrested growth amenorrhea and oligamenorrhea hypercholesterolemia hyperphosphatemia hypochloremia. Hypoglycemia hypokalemia hypomagnesemia hyponatremia hypophosphatemia metabolic acidosis metabolic alkalosis secondary hyperaldosteronism gastrointestinal acute gastric dilatation, necrosis, and perforation anorectal dysfunction constipation delayed gastric emptying early satiety elevated liver enzyme levels elevated serum amylase levels GERD hepatic injury hepatomegaly pancreatitis prolonged whole gut transit time rectal prolapse slow colonic transit superior mesenteric artery syndrome abdominal pain acute gastric dilatation Barrett esophagus bloating constipation delayed gastric emptying diarrhea dysphagia elevated liver enzyme levels elevated serum amylase levels esophageal bleeding esophageal ulcers, erosions, stricture gastric necrosis and perforation GERD Mallory Weiss tear hematemesis pancreatitis prolonged intestinal transit time rectal bleeding rectal prolapse general irritability/mood changes irritability/mood changes weight fluctuations genitourinary and reproductive acute kidney injury amenorrhea atrophic vaginitis breast atrophy infertility pregnancy complications, including low birth weight, premature birth and perinatal death, kidney stones in mother abnormal menses azotemia pregnancy complications, including low birth weight infant, continued 126 Part 2 Nutrition in gastroenterology explored and monitored. This population is also at risk of cardiac arrhythmias due to hypokalemia from purging. Ipecac abuse may result in potentially fatal cardiotoxicity, cardiomyopathy, and arrhythmias. 126 Gastrointestinal abnormalities associated with eating disorders. GI signs and symptoms are common in those with EDS, Box 9.2, also see Table 9.2. It has been asserted that the most dramatic changes in bodily function caused by an are in the GI tract. 127 There is also evidence that many individuals with EDS present with a GI complaint prior to diagnosis of or seeking treatment for an ED. 128 Cross-sectional studies of hospital inpatients with EDS have suggested that 78% to 98% have concurrent GI symptoms. 129-133 In addition, research has suggested that GI abnormalities associated with EDS may be related to the duration or presence of active ED symptoms. 134, 135 GI findings associated with EDS are listed in Table 9.2. Functional gastrointestinal disorders. GI symptoms have been shown to be more common in dieters, specifically, abdominal pain, bloating, and diarrhea, 136, and in those with binge eating, nausea, vomiting, and bloating, than in normal controls. 137 A large study of obese individuals with GI symptoms found a strong association between bed and abdominal pain and bloating after adjusting for BMI. 138 One study of 101 consecutive women admitted to an inpatient EDS program found that 98% had functional GI disorders, FGIDs, including IBS, 52%, functional heartburn, 51%, abdominal bloating, 31%, constipation, 24%, functional dysphagia, 23%, and anorectal pain, 22%. 52% of these women met criteria for greater than or equal to 3 FGIDs. 133 Another study found that the presence of IBS, but not other FGIDs, in ED patients was strongly related to disordered eating and psychological feelings. 139 Janssens Group 140 suggested that once a FGID is established in a patient with an ED, psychological and physiologic factors will strengthen each other such that FGIDs and FGID symptoms could persist independent of the current status of the ED. Esophageal symptoms. Esophageal symptoms are commonly reported in patients with EDS. Esophageal dysfunction can be obscured by bulimic symptoms 94,141 and can be misdiagnosed as an. 142 In a case control study of 23 patients, 11 restricting type and 12 binge eating/purging type, 15 patients complained of regurgitation, 6 restrictors, 9 purgers, 14 complained of heartburn, 6 restrictors, 8 purgers, and 4 complained of dysphagia, 3 restrictors, 1 purger. 143 Abnormal esophageal motor activity has also been reported in patients with an NBN. 144, 145 Mild esophagitis is common, e.g., 22% of a case series of 37 consecutive patients, in patients with chronic BN, but more serious esophageal disease is rare. 146, 147 Barrett esophagus, Mallory-Weiss tears, and GERD have been reported in association with the chronic vomiting seen with BN. 148 Esophageal rupture is a potentially life-threatening risk that may complicate chronic vomiting. 149 Spontaneous perforation of the esophagus commonly results from a sudden increase in intra-abdominal pressure combined with relatively negative intrathoracic pressure caused by straining or vomiting, Bauer-Haff syndrome. Liver abnormalities, elevated serum transaminase levels, hypoglycemia, and impaired coagulation, in the absence of other liver pathology, have been Table 9.2 selected clinical features and complications of behaviors in patients with eating disorders. Cont D system affected clinical feature or complication associated with weight loss and food restriction or binge eating in anorexia nervosa or USFT/USFT associated with purging or refeeding behaviors in anorexia nervosa, bulimia nervosa, or USFT/USFT hematologic anemia, leukopenia, neutropenia, thrombocytopenia, neurologic cognitive changes, cortical atrophy, delirium, in refeeding syndrome, peripheral neuropathy, ventricular enlargement, stroke, associated with ephedra use, neuropathy, with ipecac use, reduced or absent gag reflex oral, pharyngeal chyle-osseous halitosis angular chylitis dental enamel erosion and caries parotid gland enlargement perimyelitis pharyngeal and soft palatal trauma. Sialadenosis vocal fold pathology * specific complications of pica, rumination disorder, and ARFID, avoidant/restrictive food intake disorder, not included. Gastrointestinal complications associated with binge pattern eating in any of the eating disorders are not all listed but include weight gain, acute gastric dilatation, gastric rupture, GERD, increased gastric capacity, and increased stool volume. OSFD, other specified feeding or eating disorder, USFD, unspecified feeding or eating disorder. Box 9-2 Common gastrointestinal symptoms in patients with eating disorders: abdominal pain, belching, bloating, borborygmi, changes in appetite, constipation, diarrhea, dyschezia, flatulence, nausea. Chapter 9 Feeding and eating disorders 127-9 demonstrated in multiple studies of patients within 0.150 in one study. Elevated liver biochemical test results were documented in 4.1% of 879 patients presenting for treatment of an ED. 0.151 A probable cause that was distinct from the ED was identified in 47% of the study participants. In the remaining 53% of subjects, there was no other cause identified for the elevated liver enzymes other than the ED. Elevated liver enzymes have been reported in underweight and normal weight study participants. Study results suggest that abnormal liver biochemical tests are neither a specific nor a common marker for an ED. Other possible causes should be excluded before attributing these abnormalities to the ED. 151 Elevated liver biochemical test results and hepatomegaly may also be observed with initiation of refeeding in 149, 151 in cases where levels of indirect bilirubin are elevated in malnourished patients. Other diagnoses, e.g., Gilbert syndrome, should also be considered. There are several case reports of severe liver dysfunction or damage in patients with an attributed to malnutrition and associated hypoperfusion. 152-154 Finally, severe steatosis resulting in fatal hepatic failure has been reported in a patient with severe and 155 pancreas complications. Acute pancreatitis has been reported in patients with an NBN 156-158 and can also be associated with refeeding in 159 superior mesenteric artery syndrome. Superior mesenteric artery, SMA, syndrome is a rare disorder that can complicate an It results from severe weight loss with resultant collapse of the angle at which the SMA arises from the aorta and through which the duodenum passes. Reduction of the angle results in compression of the third part of the duodenum by the SMA. See Chapter 38.160. Because it manifests with vomiting, a concurrent diagnosis can be missed if this symptom is attributed to the ED. 161 Gastric motility. A recent systematic review revealed that controlled studies involving patients with AN were more likely to demonstrate delays in gastric motility, gastric emptying, and intestinal transit than comparator groups. 150 Similarly, delayed whole gut transit time and delayed gastric emptying have also been reported in patients with BN. 30, 119, 127, 162, 163. Numerous studies also have found abnormal gastric function in patients with EDS, including delayed gastric emptying in patients with an NBN as mentioned earlier. 30, 127, 162 to 164, but also diminished gastric relaxation, BN, 165. Bradygastria, an NBN, 134 and higher gastric capacity, BN, 135. Physiologic sequelae of disordered eating, such as contracted or expanded gastric capacity, altered gastric motility, delayed large bowel transit, through reflex pathways, 166 and blunted postprandial CCK release, may perpetuate symptoms that exacerbate the excessive body image concern driving abnormal eating patterns. 30 There is evidence that subjective reports of GI symptoms do not correlate well with physiologic data in patients with EDS. 167 Constipation. Prominent among GI symptoms in patients with an NBN is constipation. In a study of 28 in patients with an ED, 100% of patients with an N, 67% of patients with BN had constipation. 132 Constipation in an NBN is thought to be the result of poor nutrition, decreased gut motility, dehydration, and hypokalemia due to purging behavior such as vomiting or laxative abuse. Nausea, vomiting, gastric fullness, bloating, diarrhea, decreased appetite, and early satiety are commonly seen in patients with an, and bloating, flatulence, decreased appetite, abdominal pain, borborygmi, and nausea are commonly reported in patients with BN. In one study of 43 inpatients with severe BN, 74% reported bloating, 63% reported constipation, and 47% reported nausea. Borborygmi and abdominal pain were also more frequent than in the comparison group of healthy controls. 130 Rectal bleeding and rectal prolapse have been reported in patients with an NBN. 168, 169 Medications and dietary supplements. Clinicians should be aware of the many products readily available to patients with EDS that are frequently used as a means to control or reduce weight and that may also directly or indirectly contribute to GI symptoms. These products can result in significant GI symptoms and associated toxicities. Laxative abuse remains common among patients with EDS, particularly among those with BN NEAMS et al. Found that the lifetime occurrence of laxative use in patients with BN was 14.94%. 170 Other reports suggest that the prevalence of laxative abuse among patients with BN ranges from 10% to 60%. Laxatives are not an effective weight-reducing strategy, because they do not act in the small intestine where most absorption occurs. Caloric absorption is decreased only by about 12% even with extreme laxative use. The most frequently abused group of laxatives is the stimulant class. Side effects and toxicity include constipation, cathartic colon, GI bleeding, rectal prolapse, dehydration, and electrolyte abnormalities. Besides misuse of stimulant-type laxatives, patients have also been known to misuse bulk-producing laxatives, surfactants, hyperosmotic laxatives, and saline laxatives. Ipecac is an emetic that is used to induce vomiting. In a suburban ED clinic, Greenfeld et al. Found that 7.6% of patients had reported using Ipecac, 4.7% experimented with it briefly, 3.1% used it chronically, and 1.1% used it regularly. 171 Stefan et al. Reported that 18% of outpatients being treated for bulimic symptoms presented using Ipecac at some point in their life. 172 Although Ipecac is used infrequently, it can have lethal consequences, including cardiomyopathy. There are also many complementary and alternative medications and dietary supplements marketed for their potential laxative and weight loss properties. See Chapter 131. Patients with EDS should be screened for the use of diet pills, laxatives, diuretics, Ipecac, and other substances and educated about the consequences associated with misuse of these products. Other life-threatening gastrointestinal complications in rare cases, catastrophic complications have been described in case reports of patients with EDS, including acute gastric dilation, gastric emphysema, gastric necrosis, gastric rupture, duodenal obstruction, necrotizing colitis, and perforation, occult GI bleeding, attributed to transient intestinal ischemia in the setting of endurance running, has also been reported. 156, 173 to 182 In such cases, both help-seeking and diagnosis may be delayed or complicated by an undisclosed or unrecognized ED. 156, 173, 183 Gastrointestinal complications and other feeding and eating disorders. GI complications reported in association with pica include bezoar, pancreatitis, stercoral perforation, and constipation. 184, 185 Esophageal perforation has been reported in rumination disorder. 186 Management of eating disorders in the adult. The primary goal of treatment for all EDS is the normalization of eating attitudes and behaviors, cessation of ED symptoms, and 128 Part 2 Nutrition in gastroenterology where indicated, rehabilitation, and regulation, of weight. Active weight rehabilitation is a cornerstone of treatment for an as essential as weight gain is to reduce or reverse the medical and cognitive sequelae of severe undernutrition. It is one of the great challenges to successful treatment of restrictive EDS. Optimally, management of patients with EDS includes integration of mental health, nutrition, and primary care. See Fig. 9.1. Occasionally, depending on severity of ED symptoms and degree of malnutrition, medical subspecialty consultation and care are helpful. Multidisciplinary management is desirable for several reasons. First, patients are at risk of medical, psychological, and nutritional complications of their disease. Second, patients commonly selectively avoid care essential to their ultimate recovery. For example, a patient may wish to avoid detection of an injury so that she or he can continue to participate in a team sport. Another may find it difficult to undergo the psychological work necessary to address antecedents of his or her illness, or another may wish to bypass active weight management. Conversely, a patient may attempt to pursue relief for specific medical complications to the exclusion of appropriate psychological or nutritional therapies. It is often helpful, if not essential, to establish a treatment agreement at the outset of care for a patient with an ED. This is particularly relevant in patients for whom the severity of their symptoms may compromise medical and psychological health to a degree that hospital-level care will be likely necessary during the course of treatment. A treatment agreement allows caregivers to establish initial treatment goals and criteria for which they may wish to adjust the level of intensity of care. This will allow transparency of expectations for the patient, facilitate a rapid response to emerging crises, and help avoid splitting among team members during the course of care. A treatment agreement also clarifies for patients the contingencies for treatment non-adherence or poor health. As part of the initiation of care, patients should be asked to give permission for open communication among the members of the clinical team. If a patient cannot agree to this, it signals potential difficulties in providing coordinated care, and the lack of agreement should be reconciled. Depending on the patient's age and circumstances, a plan for how and what information will be shared with parents should also be established. Psychiatric treatment clinicians evaluating clinical trial data on the treatment of EDS should bear in mind that diagnostic criteria have recently been revised, and the diagnostic categories BN and BED now encompass individuals with lower frequency and shorter duration of behavioral symptoms than when these disorders were studied previously in clinical trials. Few clinical trial data are available on diagnostically heterogeneous groups. Indeed, there are limited data to guide treatment decisions for the large proportion of individuals with EDS who were formerly diagnosed as EDNOS, now OSFT and USFT. Preliminary data, however, suggest that CBT, enhanced cognitive behavioral therapy, may be effective in normal and overweight adults with a broad spectrum of eating pathology, including those formerly in the EDNOS category. 187 in adult patients, psychiatric treatment for the eating disorders N, BN, BED, and OSFT generally begins with psychotherapy. In many cases, pharmacotherapy is useful as an adjunctive treatment for BN and BED. Active weight management is indicated for N. Usually, psychotherapy can be used to support weight management goals, although optimally it should be coordinated with the efforts of the dietitian and primary care clinician on the team. Regardless of the mode of psychotherapy chosen, specific behavioral strategies directed at establishing normal eating patterns and drawing the patient's attention to triggers for abnormal patterns can augment treatment. Among these, patients are encouraged to identify and avoid emotion, schedule, and food-related triggers to episodes of binging and to plan 3 regular meals and 2 between-meal snacks to prevent excessive hunger. A food journal that can be reviewed in treatment sessions may also allow patients to better identify relationships among psychosocial stressors, hunger, and symptoms, and may provide a concrete framework from which to relate symptoms to other psychological concerns. Specific empirical data to guide treatment of pica, rumination disorder, or RFID in adult patients are lacking. 2 randomized controlled trials, RCTs, evaluating a nutritional intervention for pica did not support this approach, and there are no published RCTs on the treatment of rumination disorder. 15 Enhanced supervision or modification of the home environment may be important to prevent ingestion of toxic substances in individuals with intellectual disability who manifest pica eating. 15 Behavioral approaches to address avoidance associated with RFID may also be helpful. 188 Evaluation. Education and involvement of patient identification of most appropriate level of care outpatient residential care inpatient referrals identification of interdisciplinary team and referrals outpatient and inpatient primary care clinician, S. Mental health clinician, S. Dietitian medical psychotherapist psychopharmacologist specialty care adjunctive psychotherapist, S. E.g. group or family, division of tasks, e.g. weighing, medical parameter surveillance, dietary plan. Monitoring symptom frequency and severity, consensus on whether there will be any weight, symptom severity or symptom frequency parameters that necessitate a more intensive level of care, adjunctive treatment, or restriction of activities plan for how often and how to communicate obtain permission from the patient for communication among team draft treatment agreement if warranted initiate treatment re-evaluate and adjust care as necessary Fig 9.1 algorithm for team management of adult patients with an eating disorder. Chapter 9 Feeding and Eating Disorders 129 Psychotherapeutic Options 9 A variety of psychotherapies have established efficacy for the EDS. Recent guidelines and reviews have summarized findings from empirical studies and highlighted the paucity of recommendations for treatment of an OSFT and USFT.189-193 cognitive behavioral therapy, CBT, and interpersonal therapy, IPT, have received a great deal of research attention for the treatment of EDS. CBT is a structured, manual-based approach that addresses the relationships among thoughts, feelings, and behaviors. IPT is another short-term therapy focused on present-day interpersonal events and roles in relationships. The choice of psychotherapeutic modality will be guided by the diagnosis, medical and psychiatric comorbidities, desirability of targeting the ED symptoms versus broadening the therapeutic goals, treatment history, patient strengths and preferences, and availability of care. Initial recommendations should be evidence-based when possible, but clinical judgment is important to identify individual needs and situations where alternative treatment choices are appropriate. 190 In practice, many patients with an OSFT can benefit from a flexible approach to treatment that draws from diverse therapeutic modalities appropriate to the specific therapeutic context, because there is a dearth of empirical data to enable evidence-based recommendations and some patients do not respond to evidence-based treatments. 194 Available evidence has shown that family-based therapy, FBT, is effective in adolescents. 195, 196 FBT positions parents as key members of the treatment team who facilitate normal adolescent growth and development by releasing adolescents from the diagnosis of ED. It is now considered first-line outpatient treatment for adolescents, particularly those who are younger and have a shorter duration of illness. 197 FBT may be considered for young adults who are living with their families and where the patient and their families are prepared to engage in this treatment. 198, 199 Despite the limited evidence-based recommendations available, guidelines do suggest therapies to be considered for the psychological treatment of an cognitive analytic therapy, CBT, IPT, focal psychodynamic therapy, and family interventions focused explicitly on EDS. 190 A study that compared CBT, IPT, and nonspecific supportive clinical management in the treatment of underweight and outpatients found that the supportive treatment produced better global outcomes than IPT, and, over 20 weeks, was superior to CBT in its impact on global functioning. 200 The efficacy of CBT for underweight individuals remains unclear, but it appears useful as a post-hospitalization treatment for an contributing to improved outcomes and relapse prevention in adults after weight restoration. 201 Factors consistently predicting treatment outcome have not been identified. 191 In addition, some preliminary evidence suggests that CBT may be effective for an. 202 A number of treatments for BN have strong empirical support. CBT and IPT have been found effective, with CBT superior at reducing behavioral symptoms. 192 CBT led to faster improvement in symptoms, with better outcomes at the end of treatment, but at follow-up assessment there were no differences between CBT and IPT. 203 All guidelines recommend CBT, 16 to 20 sessions over 4 to 5 months, as the first-line treatment of choice for BN. 189, 190, 192 But not all patients respond to CBT, and IPT is an effective alternative. CBT and IPT can be delivered in a group format as well as individually. 204, 200, and 5 other promising treatment options with preliminary empirical support include dialectical behavior therapy, DBT, an approach developed for borderline personality disorder that focuses on helping patients develop skills to regulate affect. 206, and a manual-based, guided self-change approach. 207 for a subset of patients, self-help or guided self-help with an evidence-based CBT manual. 208 is an appropriate starting point for treatment in a stepped care approach. 190 or if other treatments are unavailable. 209 a variety of factors have been shown to be associated with treatment outcome in BN, but 2 emerge consistently: severity, higher frequency of binge eating, and duration of illness are associated with poorer outcomes. 192 as with BN, some individuals with BED will benefit from an evidence-based self-help program as a first step in treatment or if other treatments are unavailable. 189, 190, 209. Studies have found that self-help intervention delivered in a variety of ways, with varying levels of professional or peer support, leads to better outcomes compared with control groups, with reductions in binge eating, binge days, and psychological features associated with BED. 193 after consideration of self-help, American Psychiatric Association 189 and National Institute for Clinical Excellence 190 guidelines recommend CBT adapted for BED as an initial treatment choice. Group CBT has been found effective for treating binge eating in overweight individuals. 210, 211 there is some support for individually based CBT, although methodologic limitations preclude firm conclusions. Group IPT and adapted DBT are options to consider if CBT is not a good match for the individual or is unavailable. In one study, IPT was found to lead to similar abstinence rates as CBT at 1-year follow-up. 211 DBT has shown promising results, with a recovery rate of 56% at 6 months after treatment in 1 RCT. 212 it is important to note that treatments for BED do not usually result in weight loss, but their benefit may be in preventing further weight gain. 193 a recent systematic review and meta-analysis of third-wave therapies, conceptualized as targeting the function or awareness of cognitions and emotions, identified 13 RCTs, the majority of which focused on BED. 213 although large pre-post symptom improvements were observed for all included treatments, DBT, schema therapy, acceptance and commitment therapy, mindfulness-based interventions, compassion-focused therapy, none were generally superior to either CBT or other active comparisons. 214 as a result, the authors concluded that until further evidence becomes available, CBT should remain as the treatment of choice for both BN and BED. 214 weight loss may be identified as a primary or secondary treatment goal for individuals with BED because of comorbid obesity. Models of binge eating have proposed that dietary restriction is an antecedent to binge eating, so there has been debate about the optimal means and order of addressing concurrent binge eating and obesity. Most data, however, have shown that a variety of weight loss approaches do not exacerbate binge eating and may help reduce symptoms. One prospective study found no evidence that a reduced calorie diet precipitated binge eating in women with obesity. 215 behavioral weight loss treatment, BWLT, 216 and very low calorie diets 217, 218 have been found effective for reducing symptoms of BED. At 2-year follow-up, IPT and CBT guided self-help appear more effective in achieving remission from binge eating in BED than BWLT. 219 another study, however, reported comparable longer-term, 6-year, outcomes between BWLT and CBT for patients with BED and obesity. 220 adding exercise to treatment for BED is associated with greater decreases in binge eating and BMI. 221 although a number of studies have found that treating binge eating does not translate to weight loss, some studies have found that reductions in binge eating can assist in modest weight loss among those with BED, especially when complete remission is achieved. 222 across all diagnoses and treatments, there has been little attention to differential outcomes by socioeconomic factors. Future studies to explore whether treatment efficacy differs by gender, age, race, ethnicity, socioeconomic status, or cultural group are warranted. 191, 192. Given the frequent psychiatric comorbidity associated with EDS, as well as psychosocial risk correlates, some patients with an ED will benefit from psychodynamic psychotherapy and a flexible and eclectic approach depending on patient capabilities, goals, treatment history, and other psychosocial considerations. 130. Part 2. Nutrition in gastroenterology. Pharmacotherapy. Pharmacologic management has an adjunctive role for the treatment of BN and BED. Of the numerous agents that have been studied, only floxetine and lisdexamfetamine have US FDA approval for BN and BED, respectively. There is insufficient empiric support for efficacy of any agent in treating the primary symptoms of an. Similarly, there are no clinical trial data to support recommendations for pharmacologic management of pica, rumination disorder, ARFID, OSFD, or USFD. Finally, there are no adequate available clinical trial data to support recommendations for pharmacologic management of EDS in children and adolescents. 223. Among a variety of agents evaluated for treatment of the primary symptoms of an, several have been studied. Of these, none have accumulated sufficient evidence to result in recommendations for routine clinical use. Although some data have suggested that olanzapine may be beneficial in promoting clinical improvement in an, a recent meta-analysis failed to demonstrate superiority of atypical antipsychotics in achieving either significant increases in BMI or significant decreases in eating pathology. 224. Given the lack of data supporting efficacy and safety in patients with an, no pharmacologic agents can currently be recommended to promote weight gain in this patient population. Pharmacologic agents associated with weight gain for other indications should be used judiciously and with a candid discussion with the patient about the anticipated risks and benefits of appetite and weight changes. If such an agent is selected, symptoms should be monitored carefully to look for onset, recurrence, or increase in binging or purging behaviors. Floxetine has not been found effective for treating the primary symptoms of an in underweight patients. 225 and has unclear benefit in stabilizing weight recovered patients within. 226. 227 comorbid psychiatric illness is common among these patients and may improve with pharmacologic management, but depressive symptoms in severely underweight patients may not respond as well to antidepressant medication as in normal weight patients. Notwithstanding the very limited role for psychotropic medications in the management of an, patients will likely need to optimize their calcium and vitamin D supplementation if dietary sources are inadequate. 103 Although oral contraceptive agents may mitigate some of the symptoms of hypoestrogenemia associated with an, they do not protect against bone loss in this population. 228. 229 An observation that has been attributed to the insulin-like growth factor 1 suppressive effects of oral estrogen or the dose or form of estrogen in oral pills. Recently a study showed that estrogen administered as the 1,7-beta estradiol transdermal patch to older girls with an bone age greater than or equal to 15 years, or as small but increasing doses of oral ethinyl estradiol to younger girls, bone age 15 years, in whom growth was not complete, caused an increase in spine and hip bone mineral density, BMD, compared with placebo. However, complete catch-up in BMD did not occur with any of these measures. 230 It is useful for clinicians to bear in mind that for medical stabilization, and probably also as a prerequisite to developing the psychological insight necessary for recovery, weight restoration is the treatment of choice for underweight individuals with an. Conservative use of pharmacologic agents for low BMD in adolescents at greatest risk may be considered. 230 In contrast to the limitations of medication management for an, a number of medications have established short-term modest efficacy for the treatment of BN, although remission rates are low. 231. 232 CBT has better efficacy than medication to reduce the symptoms associated with BN, but there is some support for augmenting psychotherapy with medication, and this is fairly routine. Clinical practice. It is optimal to use pharmacotherapy as an adjunct to, rather than a substitute for, psychotherapy, but this approach may not be available or beneficial to all patients. Some evidence supports treatment with floxetine, 60 mg/day, alone in a primary care setting. 233 Floxetine has also been found superior to placebo for treating bulimic symptoms in patients who have not responded adequately to CBT or IPT. 234 Desipramine and imipramine, both at conventional antidepressant dosages as tolerated, have demonstrated efficacy in symptom reduction but are not as well tolerated in patients with BN.235. Topiramate has shown efficacy in reduction of binge and purge symptoms in 2 short-term RCTs in individuals with BN.236-238. Other agents that have demonstrated at least some efficacy, but with less data available, include trazodone 239 ondansetron, in patients with severe BN.240 and other SSRIs including sertraline, fluvoxamine, and citalopram. 232. A number of studies have investigated the efficacy of naltrexone in treating bulimic symptoms. 235 but only at higher doses was it superior to placebo in reducing symptoms in patients who had previously not responded to alternative pharmacotherapy. 241 Monitoring of liver biochemical test results is essential when this drug is used. Other medications with efficacy are relatively contraindicated for those with BN, given their potential adverse effects. Bupropion was associated with a higher than expected seizure risk during a clinical trial. 242 And there have been case reports of spontaneous hypertensive crises in patients with BN who were taking monoamine oxidase inhibitors. 243 Although fluvoxamine has shown some efficacy for BN relapse prevention in one RCT. 244 Another RCT combining fluvoxamine with stepped care psychotherapy not only did not show efficacy of this agent but also reported grand mal seizures in some participants on the active drug. 245 Similar to BN, antidepressants have generally been shown to reduce binge eating and be well tolerated in patients with BED. A variety of SSRIs, e.g., floxetine, citalopram, sertraline, fluvoxamine, as well as serotonin norepinephrine reuptake inhibitors, e.g., duloxetine for individuals with comorbid depression, have demonstrated some degree of efficacy. 232 To date, medications targeting weight management have shown mixed results for BED. Although orlistat, a lipase inhibitor, demonstrated a decrease in weight in patients with BED enrolled in a 24-week RCT, no change in binge frequency was documented when compared to placebo. 246 A more recent study in patients with BED also failed to demonstrate any reduction in binge episodes when compared to placebo. 247 Although topiramate has demonstrated some efficacy in reducing binge symptoms and weight in patients with BED, side effects and high attrition rates limit the generalizability of the findings for this population. 232 In early 2015, lisdexamfetamine, a prodrug of dextroamphetamine, was approved for the treatment of moderate and severe BED in adults. Studies have found the medication to be effective and associated with minimal adverse effects. 248 However, a recent long-term study, 52 weeks, documented mild to moderate adverse effects in 84.5% of enrolled patients and drug discontinuation in 9% of cases. 249 Physicians considering the use of stimulant medications for the treatment of BED should closely monitor heart rate, blood pressure, and general cardiovascular health in these patients. Nutritional rehabilitation. Severely malnourished adult patients, especially those 70% to 75% of expected body weight, may require inpatient care for refeeding. Patients with AN are at particularly high risk for refeeding syndrome, which can occur with any means of refeeding, including oral, enteral, and parenteral routes. See Chapter 6. 250, 251 Refeeding syndrome, which typically manifests with hypophosphatemia, also known as refeeding hypophosphatemia (RH), in the setting of depletion and cellular shifts in the early weeks following refeeding, can result in multiple medical sequelae, including delirium, heart failure, and death. 112, 252. Evidence suggests that the degree of RH is Chapter 9 Feeding and Eating Disorders 131-9 correlated with degree of malnutrition, % expected body weight or % median BMI, on admission to the hospital as opposed to the introduction of low or high calorie nutrition. 250, 251. 253 A recent systematic review found that higher calorie approaches, greater than 1,400 to 2,000 kcal/day, to refeeding in mildly or moderately malnourished patients, either via meal-based or combined NG tube feedings and meals was effective and safe. 251 Finally, one study found RH was also associated with rate of weight loss before admission, but not prescribed caloric intake. 254 Collectively, This work suggests that the degree of malnutrition at presentation may be more important than the amount of energy intake in contributing to the risk for the development of RH. As such, physicians should be cautious when refeeding severely malnourished patients, 70% median BMI. In severely malnourished inpatients, however, there is insufficient evidence to change the current standard of care. Further studies to determine the best possible nutritional intervention to result in safe weight gain in hospitalized and non-hospitalized patients are necessary. Currently, it is recommended that serum electrolytes including phosphorus and magnesium levels should be monitored closely, e.g., 6 to 8 hours after feeding begins, during at least the first week of refeeding. 255 Heart rate, respiratory rate, lower extremity edema, and signs of heart failure should also be evaluated daily for at least a week and then intermittently at longer intervals as the patient stabilizes. Cardiac telemetry should be used to monitor heart rhythm so that supplementation and other appropriate measures can be instituted if RH or other signs of refeeding syndrome develop. Delirium may occur in the second week of refeeding or later and may last for several weeks. 256-259 Some experimental data have suggested that a healthful dieting intervention may be helpful in reducing bulimic symptoms. 260 But conventionally, weight loss treatment has been discouraged in patients with BN, because dieting can stimulate binging and purging. BED is common in individuals who present for obesity surgery with some, but not all, symptoms of the full clinical syndrome. Medical management of gastrointestinal symptoms. Individuals with EDS are likely to have concurrent GI symptoms for which consultation may be sought. In some cases, behaviors associated with EDS result in serious GI complications. In other cases, GI symptoms may be mild and not correlate with underlying pathology but may compromise efforts to nutritionally rehabilitate the patient. Given that the restrictive eating, binge pattern eating, and purging behaviors may underlie or exacerbate some of the GI symptoms, concurrent management of the ED is integral to preventing worsening of the GI manifestations of illness. Careful differential diagnosis is also necessary to avoid misattribution of symptoms to a feeding or ED and to detect primary GI pathology that may be obscured by one. Subjective reports of GI symptoms may not reliably indicate pathology. 146, 261, moreover, they may be mediated by affect 123 or body image concerns. 114 When patients complain of bloating and constipation, it is useful to determine to what extent these complaints stem from fear of gaining weight or reflect decreased GI motility. A number of studies have evaluated improvement in GI function after nutritional rehabilitation. These studies have yielded mixed results, however, and conclusions have been limited by small sample sizes and non-randomized designs. In one study, gastric emptying improved in patients with restricting type 1 but did not improve in patients with binge eating/purging type 1 after a 22-week treatment period of increasing dietary intake and CBT. 146 Self-reported GI symptom scores improved after treatment in this same study but remained abnormal and did not correlate with gastric emptying as evaluated by U.S. examination. 146 Another study of a mixed sample of adolescents and adults with and did not demonstrate significant improvement in gastric emptying after weight gain, n equals 6, despite normalization of heart rate and blood pressure. 262 Other studies have suggested that nutritional rehabilitation is associated with improved gastric emptying in inpatients with an, but it is unclear whether such improvement is related to refeeding per SE or to weight gain. 263 Constipation is a frequent complaint of patients with an NBN and may have multiple causes. Colonic transit appears to be delayed in patients with constipation in an, but returns to normal within 3 to 4 weeks of refeeding in hospitalized patients within. 127, 264 In one study, however, anorectal dysfunction in patients with severe constipation did not significantly improve with refeeding. The investigators suggested that abnormal defecatory perception thresholds and expulsion dynamics in an may have contributed to the patient's unremitting constipation. 264 From 10% to 60% of patients with AN265 and BN266 abuse laxatives, most commonly of the stimulant class. 267 Some patients use laxatives as their chief method of purging and may gradually escalate their daily dose to very large amounts. Although the relationship of laxative abuse to colonic dysfunction remains controversial, see Chapter 128, 268-270. It has been observed that patients with chronic laxative abuse complain of constipation while tapering off their laxatives. Rectal prolapse has been described with an NBN and is thought to be linked to constipation, laxative use, excessive exercise, and increased intra-abdominal pressure upon self-induced vomiting. 138. 162 other medical concerns associated with laxative abuse include electrolyte and acid/base changes that can involve the renal and cardiovascular systems and may become life-threatening. The renin-aldosterone system becomes activated upon fluid loss, which leads to edema and acute weight gain when the laxative is discontinued. This can reinforce further laxative abuse when a patient feels bloated or experiences weight gain. 267 Delayed intestinal transit and its associated clinical symptoms present a particularly interesting clinical challenge in patients with an NBN. Existing data suggest that re-establishing regular food intake or weight gain will improve delayed gastric emptying and slowed colonic transit, although this may not be sufficient to restore normal GI function. Patients may resist active weight management or cessation of their disordered pattern of eating despite having a serious ED and associated GI complications. This resistance may be exacerbated by early satiety, abdominal pain, bloating, or constipation, all of which may reinforce the patient's excessive concern with weight or conviction that his or her diet has to be further restricted. Management of symptoms is further complicated by subjective symptom reports that do not correlate consistently with pathology. Some complaints may be mediated by psychiatric symptoms or illness, including depression, anxiety, or distorted body image. Because refeeding and establishing normal and healthful dietary patterns are both treatment goals and likely to improve symptoms, careful nutritional rehabilitation is a reasonable and conservative initial step in managing suspected delayed gastric emptying and slow colonic transit for inpatients with an ORBN. Patients are likely to benefit from the support and reassurance that many of the GI symptoms commonly associated with EDS, e.g., bloating, constipation, nausea, vomiting, diarrhea, will improve as eating and weight return to normal. Additional management strategies include dietary changes to reduce bloating, such as promoting smaller, more frequent meals, encouraging consumption of liquids earlier in the meal, and possibly initially providing a percentage of calories, no more than 25% to 50%, in liquid form. 72, 116 Various prokinetic agents have been used to manage delayed gastric emptying in an, although existing data do not support a recommendation for their use for gastric motility complaints in an. 271 132 Part 2 Nutrition in gastroenterology. Some clinicians have reservations about prescribing laxatives to treat the constipation that follows laxative abuse. Although it does not make sense to reproduce purging behavior using cathartics to treat constipation in this situation, some patients will benefit from a thoughtful bowel regimen to reduce discomfort and bloating. Increasing fluid intake, dietary fiber, and adding stool softeners and bulk-forming agents are often reasonable and conservative first-line treatments. Osmotic laxatives may be necessary for symptom relief in some cases. 272 Management of constipation may require anorectal retraining if it is due to anorectal dysfunction. See chapters 19, 128. and 129. 264 Some patients may benefit from symptomatic relief of GERD and esophagitis with antacids or H2RAS. PPIs may be required for relief of more severe symptoms. 72 Although such treatment may be appropriate clinically, the underlying cause and exacerbation of the GI complaint should be made clear to the patient and, when related to the ED, actively addressed in psychotherapeutic treatment. Mild elevations of serum aminotransferase levels in and secondary to malnutrition will likely remit with weight restoration. Elevated serum levels of liver enzymes in severely ill patients may be an indication of refeeding syndrome or reflectin-related hypoperfusion and require emergent evaluation and intervention. 72,175 Although many GI symptoms related to restrictive eating, binge pattern eating, or purging can be managed conservatively, some GI complaints will require further diagnostic evaluation. Anecdotal reports of catastrophic GI complications of EDS, as well as primary GI illness that arises coincidentally with an ED or mimics an ED, suggest that complaints should be evaluated in their specific clinical context. SMA syndrome manifests with vomiting and can be missed if this symptom is attributed to the ED alone. There are case reports of ED-related gastric emphysema resulting from gastric muscular atrophy, occlusion of the gastroesophageal junction, and delayed gastric emptying. 273 Acute gastric dilatation is a rare complication of an binge/purge subtype that results from decreased gastric motility and delayed gastric emptying. 178. It may be unsuspected in the absence of a clinical history of binge eating. 169 If acute gastric dilatation is confirmed in the setting of refeeding or in the presence of a history of an ED with binge eating, urgent NG decompression and fluid resuscitation are necessary because gastric necrosis, perforation, shock, and death can occur if treatment is delayed. 178 In some cases, laparotomy may be necessary. 133, 136, 169 More clinical trial data to clarify treatment strategies for GI complaints associated with the feeding and EDS are warranted. However, management of GI symptoms in patients with an ED can be guided by several key considerations. Primary GI illness should be excluded and where appropriate, consideration that a feeding or ED may be obscuring or mimicking a primary GI illness. If functional GI symptoms appear to be associated with an ED, nutritional rehabilitation in combination with psychotherapeutic care should be considered as an initial step. Nutritional rehabilitation in an will often require inpatient care and monitoring for serious potential complications like refeeding syndrome and acute gastric dilation. During treatment of an ED, resistance to weight gain, to eating normally, and to cessation of binging and purging is common, so the possibility that body image or emotional symptoms can result in medical GI complaints should be considered in the treatment plan. Eating disorders and the intestinal microbiota. Recent research suggests that the intestinal microbiota is likely to play an important role in the cause, progression, and treatment of EDS. The intestinal microbiota is necessary for normal physiology, and this is underscored by the role of the intestinal microbiome in metabolic diseases. The intestinal microbiota can be conceptualized as a community of microorganisms, including bacteria, archaea, fungi, parasites, and viruses, found within the human GI tract. See Chapter 3.274. The composition of an individual's intestinal microbiota is unique, and the relationships that the microbiota has with human health and disease is influenced by a number of host factors including, but not limited to, genetics, nutrition, health and nutritional status, age, sex, geography, and exposures. 275 Although studies involving the microbiota and EDS are limited, emerging research suggests that patients with EDS have an altered intestinal microbiota, dysbiosis. 275 Dysbiosis has been thought to alter the gut-brain axis and to have an impact on appetite control and brain function that may contribute to the development of an ED. It is also thought that abnormal feeding behaviors and psychological stress feed back to the intestinal ecosystem, influencing physiological, cognitive, and social functioning. This relatively new area of study requires further exploration to help understand how intestinal microbes impact the human host with respect to the etiology of EDS and how the intestinal microbiota changes over the course of the illness. Understanding the role of the intestinal ecosystem in EDS could facilitate the development of novel microbiome-targeted treatments that may facilitate weight gain, improve GI tolerance during refeeding, and help ameliorate mental health distress via the brain-gut microbiota axis. 275 Ultimately to improve the outcome of EDS. Acknowledgement. The authors would like to thank N. E. Becker and Sarah A. Carney for their enormous contribution to this chapter in the 10th edition.